Welcome to this explainer. Today, we're stepping right into the delivery room to examine one of the most critical, high-stakes scenarios in modern medicine. We're taking a really fascinating deep dive into exactly how medical professionals safely navigate stalled labor. Now, childbirth is a highly dynamic process, right? But what do doctors do when things just suddenly stop moving and time is completely of the essence? Well, we're going to look at the exact protocols, the specific instruments, and the incredibly rigorous safety checks that guide these intense moments.
So, picture this for a second. A mother has been in labor for hours. She's reached the very final stage, but natural progress has just ground to a halt. Either she is completely exhausted, or the fetal heart rate monitor is starting to show signs of distress. We are looking at those crucial moments when natural progress stops and intervention becomes absolutely necessary. What's the next step to ensure both the mother and the baby are safe?
Okay, let's dive into this. The solution in these really intense scenarios is often an assisted vaginal birth. Clinically speaking, this is the use of obstetric forceps or a vacuum extractor, which is also known as a ventouse, to expedite a vaginal delivery. Now, if you're not a medical professional, the idea of using instruments during childbirth probably sounds a little intimidating. But as you'll see throughout this explainer, this is fundamentally a life-saving solution. It's a highly structured, carefully calculated procedure designed to safely assist a baby out of the birth canal when pushing alone just isn't cutting it.
To really understand how this works, we're going to follow a precise clinical roadmap today. First, why assisted delivery? Second, the safety checklist. Third, choosing the right instrument. And finally, managing complications.
All right, let's jump straight into Section 1, why assisted delivery. Before we even talk about the tools themselves, we really need to understand the specific physiological problems that demand them. Because instruments are never, ever used lightly. The decision to intervene is this incredible balancing act, based on protecting the mother, the baby, or sometimes both. For the fetus, the primary indication is suspected compromise. If electronic fetal monitoring is showing a pathological heart rate, or if there's thick meconium present, that baby needs to be delivered quickly. On the maternal side, it often comes down to sheer exhaustion or a prolonged second stage of labor. Clinical guidelines define that as 1 to 3 hours of active pushing, which varies depending on whether it's her first baby and whether she has an epidural. And finally, there are strict medical indications to avoid pushing altogether. If a mother has severe cardiac disease, a hypertensive crisis, or a cerebral vascular malformation, the intense physical straining of pushing could literally be life-threatening. In those cases, the instruments step in and do the biomechanical work for her.
And this brilliantly illustrates a key dilemma. Why not just do a cesarean section? Well, when the baby's head is already deep down in the maternal pelvis, performing a second-stage C-section is actually associated with some major risks. We're talking severe maternal hemorrhage, a much longer hospital stay, and higher risks of uterine tearing. So when the clinical criteria are met, an instrumental delivery avoids those surgical risks. It prevents a deeply impacted fetal head from having to be pushed back up and delivered through the abdomen. It's a really delicate, high-stakes balance of choosing the safest biological route.
Which brings us to Section 2, the safety checklist. Because the stakes are so high here, modern obstetrics is built on this massive foundation of safety first. Doctors don't just grab an instrument and hope for the best, they follow a really rigid, methodical preparation phase. The authoritative BJOG guidelines state it perfectly. Safe assisted vaginal birth requires a careful assessment of the clinical situation, clear communication, and expertise. I really want to emphasize this because it reassures us that these tools are strictly regulated. Using forceps or a vacuum requires informed consent, explicit communication with the mother, and a highly trained operator who knows exactly what they are doing. To make absolutely sure nothing is missed, clinicians use a brilliant tool straight from the Oxford Handbook of Obstetrics, the forceps mnemonic. Let's look at the first 4 crucial prerequisites a doctor must check before ever reaching for an instrument. F stands for fully dilated cervix. Pulling a baby through an incompletely dilated cervix will cause severe tearing, so that's a no-go. O means obstruction excluded. The fetal head has to be engaged in the pelvis, and cephalopelvic disproportion must be ruled out. R is for ruptured membranes and reviewing the procedure. And C reminds the doctor to obtain consent and catheterize the bladder. Why? Because an empty bladder actually creates more physical room in the pelvis and prevents urinary tract injuries. Let's move to the second half and see how this builds into the placement and comfort checks. E means explain the procedure and ensure adequate analgesia, like an epidural or a pudendal block. P is absolutely critical. The doctor has to determine the exact position and presentation of the baby's head, check the power of the mother's contractions, and ensure perfect placement of the instrument. And finally, S stands for station, which means confirming exactly how low the baby's head is in the pelvis and calling for senior help if needed. Only when every single one of these boxes is checked off can the procedure actually begin.
Conversely, this strict checklist tells doctors exactly when these tools cannot be used. These are your absolute contraindications. If the cervix is incompletely dilated, if the fetal head is high and unengaged, if the baby is just too big for the mother's pelvis, a condition called CPD, or if the fetus has known bleeding disorders or bone fracture predispositions, instrumental delivery is completely off the table. This objective problem-solution backbone ensures instruments are only used when they are mathematically and biologically the safest option. Now we enter Section 3, choosing the right instrument.
So, once the safety checks are totally cleared, the obstetrician has to tailor their tool choice to the specific clinical scenario in front of them. They essentially have two main options, forceps or a vacuum extractor. Now, what's really interesting when we compare these two is the stark contrast in medical trade-offs. Forceps use curved metal blades to cradle the baby's head and apply traction. They have a really high success rate, but they carry a higher chance of maternal perineal trauma and a slight risk of facial marks or temporary facial nerve palsy for the baby. On the flip side, the ventouse, or vacuum, uses a suction cup. It's much gentler on the mother, causing way less pelvic floor trauma. However, it does have a higher failure rate. The cup can literally just pop off if pulled too hard, and it carries a higher risk of scalp swelling, known as a cephalhematoma, for the infant.
Because of these really distinct physical impacts, context is everything, and there are situational contraindications. For example, a vacuum extractor is absolutely contraindicated before 32 to 34 weeks of gestation. Why? Because a premature baby's scalp and blood vessels are simply too fragile for that kind of suction. The vacuum is also totally useless for face presentations or for the aftercoming head of a breech baby. In all of these specific scenarios, preterm birth, face presentation, or breech, forceps become the mandatory, necessary choice.
And to add to that, the doctor's toolkit is highly modular and adaptable. Under the umbrella of forceps, you have Wrigley's forceps, which are short and light, used when the baby is right at the pelvic outlet. But if the baby's head is stuck facing the wrong way, a doctor might reach for Keelan's forceps. These lack a pelvic curve and are specifically designed to safely rotate the baby's head. Over on the vacuum side, doctors can choose soft silicone cups for straightforward pulls or rigid Omni cups if the baby is in a trickier position. The key takeaway here is that the instrument is always matched exactly to the baby's unique position in the birth canal. I want to pause and highlight this critical number 3. Clinical guidelines strictly dictate that an operator must abandon the procedure if there's no evidence of progressive descent after 3 pulls. Similarly, if a vacuum cup pops off twice, the procedure is halted. This strict numerical limit is there for a very good reason, to protect the baby from prolonged excessive traction, which is a major cause of birth trauma. If 3 pulls don't work, the plan must instantly change.
Which seamlessly brings us to Section 4, managing the complications. We have to acknowledge that while these are safe procedures performed thousands of times a day all over the world, they are still operative interventions, and all operations carry inherent, manageable risks. Modern guidelines are incredibly transparent about this. For the mother, complications can include postpartum hemorrhage, vaginal tears, and, most notably, obstetric anal sphincter injuries, or OASI, which are definitely more common with forceps. For the fetus, the vacuum can cause cephalhematoma or, very rarely, a dangerous subgaleal hemorrhage, while forceps can cause temporary facial nerve palsy. But beyond the delivery room, guidelines heavily emphasize the need for long-term care. This includes postnatal physiotherapy for pelvic floor recovery and crucial psychological support for mothers who experience these really intense, fast-paced deliveries. So the crucial point is understanding this vital clinical boundary. Doctors try very, very hard to avoid what is called sequential instruments. If a doctor tries the vacuum and it pops off twice, reaching for the forceps next significantly multiplies the risk of severe trauma to both the mother's pelvic floor and the baby's brain and scalp. It's a really difficult clinical moment. The obstetrician has to rapidly balance the elevated risks of using a second instrument against the massive surgical risks of performing a deeply impacted cesarean section. Because of these exact risks, hospitals have a rigorous fail-safe protocol for managing a failed attempt. Step 1, stop the procedure and assess. Step 2, call for senior obstetric and neonatal help immediately. Step 3, transfer the mother to the operating theater. In fact,
If a delivery looks particularly complex from the very start, doctors will actually perform a trial in theater, meaning they attempt the instrumental delivery right there on the operating table. That way, if it fails, they can instantly pivot to step 4, proceeding directly to an emergency cesarean section. It is a highly choreographed, incredibly fast pivot just to ensure safety. But ultimately, all of this structure relies on the human element. The guidelines summarize it beautifully. Operators should be aware that no indication is absolute, and the clinical judgment is required in all situations. The guidelines provide the rigorous checklist, the clever mnemonics, and the safety limits. But the true art of medicine requires the human expertise to read the room, evaluate the patient, and adapt to a constantly changing biological reality. Which leaves us with this final thought. Assisted vaginal birth is one of the most direct examples of medical intervention in a natural process. It forces us to ask, how do we perfectly balance the urgent need for life-saving intervention with the profound responsibility of keeping both mother and child safe from harm? It's a delicate, highly structured reality of modern assisted childbirth, relying on incredible skill, strict rules, and a deep respect for human life. Thank you so much for joining me for this explainer, and I hope you walk away with a newly structured understanding of this incredible medical toolkit.